Welcome to the first session of our second virtual education series. And this is a session on biologics, and we are so excited to have all of you here tonight. My name is Jennifer Wilson, and I am the Executive Director of Cassie and Friends Society. And our mission is what you see on the screen there, to transform the lives of kids and families affected by both juvenile arthritis and other rheumatic diseases. And one of the ways we are doing that is through sessions and information like we are providing tonight. So before we get started, I just want to quickly thank our sponsors. Nicola Wealth Management, AbbVie, Amgen Canada, and Sobi have all been critical in us being able to provide this information and also a sense of connection to our community from coast to coast across Canada, as well as internationally. And we are so thankful for their support in being able to host these educational series. So who's in the room tonight? We're really excited to have 105 people online tonight. And those people, as I said, come from coast to coast across Canada, as well as 5 additional countries across Canada. We always get started, so if you haven't yet had the opportunity, do introduce yourself in the chat box, which you'll see at the bottom of your screen. It's a great way to feel like we're actually in a room together and getting to know one another. Biologics was actually one of the most suggested topics that we had from all the past surveys of virtual education series to date. And so we thought also in the chat box, if you want, you can do your name, you could say the name of your child or the age of diagnosis. You could mention if you're on a biologic, and if you're wanting to try something different, you could put in one word that comes to mind when you hear the word biologics. So I mentioned that this is the season 2 of our virtual education series, which means that there was a season 1. And I'm really excited to let you know that all of those past sessions can be found on our website at cassieandfriends.ca. So you can see some of the examples of sessions we've had in the past, and all of those recordings are available online for you to either catch up on, or when you need to refresh, or maybe you're in a new stage of your child's rheumatic disease journey, and a topic now is more relevant than ever. So we're excited to provide that information and hope you will go access it. That virtual education library is also further supported by a resource hub on our website. And our resource hub is, as you can see, it covers a variety of topics that have been really important to youth and families in our conversations with them. And on those pages, you're going to find over 300 question and answers from live sessions that have been indexed, so real concerns and questions from patients and families. You're going to find the webinars, which have been time-stamped, so you can get to the information that you're looking for easily. You're also going to find real patient and family stories, links to relevant research, and other resources as well. And all of these pages have been reviewed and supported by the work of our Medical Advisory Committee, who we are very excited to have participating in this webinar tonight. So before we get started, I'm just going to quickly go over what happens next after this webinar. So most importantly, session survey. You're going to get a link right after the webinar, and that is really critical in providing your feedback to us to let us know how this session was, did it answer your questions, but also to give us ideas for all the future sessions we're planning. Again, as I said, biologics was one of our most requested session. So you can see that we really take that feedback to heart. We want to hear what you have to say. Our next session is for anyone who's interested in what happens when your child will start to transition out of pediatric care into adult rheumatology. And please don't think that this is only for you if you have a teen, because the transition process can start very early in helping your child to gain skills to take independence in their healthcare step by step. But this is going to be a really exciting session. We're going to have clinic representation in breakout rooms from across the country, and also we'll have 3 speakers sharing different aspects of how they took the reins in their own healthcare. Team Cassie and Friends is on full throttle across the country, and we've now moved into our Calgary, Toronto, and Halifax races. So you can go to cassieandfriends.ca/run. And this is a way to really be a part of the Cassie and Friends community, not only to raise awareness, but help to raise important funds that allow events like this and all the resources to happen. And lastly, our next session for our virtual education series is going to focus in on another important topic, very related to biologics, which is injection support. Okay, so just a few housekeeping notes before we get started. If you just joined us and you're looking for our French recording, there is a simultaneous broadcast. So just in the box below, you'll see an interpretation button, and that is where you can join the French broadcast if you prefer. As Kelly mentioned in the chat box, all your mics are muted, so don't worry about that. And please do keep your video off. Finally, if you're having any technical difficulty, you can always access the dial-in option, and that was provided in your registration email. So feel free to join in whichever way works for you. And finally, the question and answer. So this is a really exciting part of our sessions. We're so pleased that we can have this really like open dialogue and discussion and a back and forth, and to hear from you as well, and have an opportunity to directly speak with our youth speaker and our medical speakers. So also in the box below, if you scroll your arrow down, you'll see a chat box, but for the Q&A, it would be great if you used actually the Q&A button, and you can just pop your question in there and we'll answer them. After the session, if you have a question that you didn't get a chance to answer, please do email it to us, because we try our very best to get all questions that weren't answered, either answered by our medical advisory committee or providing written answers, which will be uploaded to our resource hub. And with that, I'm very excited to introduce our first speaker. Julie Beausoleil is our youth speaker tonight. She lives in Ottawa, Ontario, where she is attending the University of Ottawa and pursuing a Bachelor's of Commerce. Julie is an adrenaline junkie, which I hope we hear more about. And she is also a beautiful writer, and lucky for us, one of the things she loves writing about is her experience growing up with juvenile arthritis, which she's done for both the Cassie and Friends blog as well as for Take a Pain Check, which is a podcast. And with that, I'm really excited to welcome you, Julie. Thank you so much for joining us, and we look forward to hearing from you.
Thank you so much, Jennifer. I am so excited to be here today. Just sharing my screen. Perfect. All right, so as she mentioned, my name is Julie, and just to introduce myself, even though that was already done, I am 20 years old and I have juvenile rheumatoid arthritis. I'm also from Ottawa, Ontario, and I'm very excited to be here today to talk a little bit more about my experiences and my story and my experiences with biologics specifically. So to start, I'll go over a little bit about my diagnosis just to provide some context and some backstory. Then I'll move on to my experience with the two main medications that I've been on, which are Methotrexate and Enbrel. And then I'll dive into my specific experience with biologics. And finally, I will explain some other medication considerations that I never really thought about as a child growing up, but now that I've transitioned to adulthood, they're a little bit more prevalent in my mind. So to start with my story, I was diagnosed very young, and there's a little bit of a story to that. So I would stand in my crib and cry for my parents as a toddler to come and get me, as any healthy child typically would. But then one day my parents noticed that I wasn't standing and crying for them. I was sitting and crying for them. And then a couple of days later, they noticed I wasn't sitting and crying for them. I was actually lying down and crying for them because I was unable to move. Clearly something was wrong, so they decided to take me to the hospital, where I was quickly diagnosed with juvenile idiopathic arthritis at 18 months old. Luckily, I did receive my diagnosis fairly quickly. But because I was diagnosed so young, I didn't know anyone else who had my condition. And growing up through elementary school, through middle school, I always wanted to fit in and I didn't want to be different. So I typically hid my condition and I kept it on a need to know basis. I would only tell people if I absolutely have to. Other than that, I just kept it between me and my parents. However, as I got into my teenage years, I found a wonderful community of other young people with arthritis and other rheumatic conditions, and some of them are even my best friends to this day. This helped me so much with embracing my condition, and I'm no longer ashamed. I'm no longer embarrassed. I feel confident enough to speak about it with everyone. I actually like advocating now. I write blogs about it, and I like connecting with other people who are in similar boats. It's definitely helped the experience a lot. So having JIA has definitely had its ups and downs, but without it, I wouldn't have had the opportunity to become resilient and determined. So I'm very grateful for all the experiences it has given me and all of the life experience that I've endured. So now to get on to my medication journey. The first medication that I remember taking, it's a long time ago, was Methotrexate. I did take some before that, but this is the first that's in my memory because I was so young. I was about 4 years old. So to give some context, Methotrexate is a DMARD, it's not a biologic. But I was on the Methotrexate pills. I took about 6 pills per week and I took them all in one day. Unfortunately, though, I did experience some side effects from Methotrexate. The main one and the worst one being nausea. Every time it got to the point where every time I took the pills, I would end up getting sick to my stomach and I wasn't able to keep them down essentially. I took the pills for many years, but even after I stopped taking the pills, I had trouble taking pills for many years after that. My parents and I tried many different methods to help this process. We would chop up the pills, we would put them in yogurt, we would put them in applesauce, we would put them in pudding, you name it, we tried it. But I would still get nauseous even when I would try those foods after, even if the pill was not actually in it, just because of how nauseous this medication made me. So after a discussion with my parents and with my pediatric rheumatologist, we decided to switch to Methotrexate injections. At least with the injections, I was able to insert the medication and ensure that it actually entered my system rather than coming back up. However, the nausea still persisted, just in a little bit of a different way. I would have to lie in bed for a few hours after my medication just because I was so nauseous. And I remember the specific color of the medication, actually. The liquid was this certain shade of yellow. And anytime I would see that specific shade of yellow, I would also get nauseous again. I remember one time I was hanging out with my friend when I was about 8 years old, 9 years old, and we were drinking apple juice out of a yellow cup. So the combination of the yellow from the apple juice and the yellow from the cup just did not sit well with me, and I became very nauseous. But that was that. And unfortunately, however, the Methotrexate stopped working properly for my arthritis, and I needed to change methods on how to actually treat my condition. So I was on a transitionary period for about 6 months where I was transitioning from Methotrexate to Enbrel, which is a biologic. I would take 1 needle of Methotrexate and 1 needle of Enbrel every single week. And after this 6 months, I was fully switched to Enbrel. My mom was the one who would administer this needle, so I was very dependent on her for my care. She was the one, and my father as well, who would refill my prescriptions, pick up my prescriptions, drive me to the doctors, book my doctor's appointments, mix my medication, administer my medication, dispose of the needles, and pretty much everything. But again, I was only about 10 at the time, so that makes sense. But I remember one day when I was about 12 years old, my mom and we had an argument. I don't even remember what the argument was about, but I do know that it was on medication day. So when she came up to my room to administer my medication, we were both still kind of mad. So my adrenaline was pumping very high, and I ended up just taking the needle from her and stabbing it in my leg. And ever since that day, I've been able to administer my own injections. So although I don't even remember what the fight was about, I'm very grateful for it because it made the process of learning how to do this on my own so much easier because it wasn't planned and it was a spur of the moment decision. That being said, by being able to administer my own needles, I gained a very big sense of independence. And then over the next couple of years, I became pretty independent for my whole care process. I would refill my own prescriptions. I would pick them up. I learned how to mix and measure the doses of my medication and administer them, dispose of them. I was more in control of all of my appointments. Of course, my parents still supported me and my family still supported me, but I did have the sense of independence. And I was really grateful for that. I love having the sense of independence because it feels like I'm more in control of my own condition, and it feels like I know how to manage my own condition better. So one piece of advice I would give to anyone who has children with arthritis or with any chronic illness would be to try to involve them in their care process throughout. Obviously, the levels of involvement will correspond to individual situations and age and how comfortable they are with different things. But I would definitely recommend doing this because it gives you such a sense of control and it makes you understand your condition better, and it will help with the process of transitioning to independence as they get older anyways. Now, I've tried 2 different types of injections for Enbrel, which is the biologic. The first method, which is my preferred method, is where I would manually mix the medication and measure it in the syringes. By doing this, when I would actually inject myself with the medication, I can control the pace at which the liquid comes out. And I found the pain very mild, and I found it very easily overall. However, I did try another method. I tried the auto injectors. I did this for about a 2-month period. And the auto injectors are kind of EpiPen styled. So how it would work is you would hold it to the injection site and you would press the button and then everything else is automatic. So the needle would inject and then at the predetermined rate, the liquid would come out and go into your system. With this, however, I wasn't able to control the pressure at which the liquid came out. So I found it very, very painful. And my legs did not react well to it either. After I would inject and remove the needle, my legs would swell up kind of like the size of mini ping pong balls or mini golf balls. So it wasn't too nice. But after doing this for a couple of months, I switched back to the manual syringes where I would measure, and I've stuck with that to this day. And I personally, I do think it's a lot easier, more pain-free, and just a better option for me. But one tip I would give for anyone who's struggling with injections or is looking to just start injections, or if you have a younger child who is going to start injections, would be numbing cream. What I did when I was a kid is I would take Emla cream, which is a specific type of numbing cream, and I would put it on the injection site, so one on each thigh, and I would wrap my legs in saran wrap, kind of like a sandwich, and I would let it sit for about 1 hour so that the area was numbed, and then by the time I got the medication, I could barely feel it. So that definitely helped the process, and I would highly recommend. I don't need to do this anymore, but it's definitely a good measure. Now to dive into my specific experience with biologics. It's fairly short because it's been pretty positive. I honestly haven't felt very many side effects at all. Unlike the nausea that I felt with on Methotrexate, with Enbrel, the biologic, I have not felt any side effects. However, I have been on medication for a very long time. So I found that I often forget how reliant I am on my medication to manage my pain at the way that I do and to feel the way that I feel. And I only had this realization a couple of months ago. When I received my COVID-19 vaccine, my doctor recommended skipping my Enbrel dose for 2 weeks just to ensure that my medication didn't interrupt the efficacy of the COVID-19 vaccine. But on the day that I actually did receive my Pfizer shot, I was already due for my next Enbrel dose. So by the time I waited the additional 2 weeks, I was already about 3 weeks without medication. And by the 3rd week, I felt more disabled than I have in a very, very, very long time. And it was a huge reality check. I struggled with all daily tasks, with standing, with getting in and out of the shower, with getting in and out of cars, with walking. And it made me do some deep reflection. And I realized how dependent I really am on my medication and how much of a difference it does make in my life. And it also made me realize how grateful I am to actually have access to this medication and to have access to a medication that works for me. This leads me to some other considerations I didn't consider as a kid, but now that I'm older, they're definitely on my mind. Knowing that I'm so dependent on this medication, it makes me think about how I need to ensure that I have access to this medication as long as I need. And currently I'm covered under my parents' insurance. Even if I wasn't, I believe I'd still be covered under OHIP, which is the Ontario Health Insurance Plan, until I believe 25. That could be wrong, but that general area. And then after this, I believe I do need my own personal insurance coverage. Now, a lot of people, a lot of 20-year-olds don't really think about medication and don't think about insurance coverage when they're going to school or when they're figuring out their lives. But this is something that always has to stay in the back of my mind. I have to make sure that I'm succeeding in school so that I can set myself up to get a good, stable job that has health benefits so that I can actually access this medication. This is a stress factor that that I've definitely experienced over the past few years, because although I still have 5 years until I'm 25, that's only 5 years. It's not a very long time. And if I didn't have any insurance whatsoever, I would not be able to afford the medication. So this is something I just need to keep at the back of my mind. And it's something that's not discussed very much. So I just wanted to bring it to light just to talk about it. And another aspect of this is travel considerations. I have great aspirations to travel. I'd love to study abroad. I would love to live in different countries and immerse myself in different cultures. But one thing that's always at the back of my mind is my medication access. Again, I have to make sure that I plan ahead and work out the logistics of insurance and make sure that I can access it through different pharmacies, or if I can bring it with me to my destination. There's so many other implications that I never really thought about growing up, but they are definitely prevalent in my adult life. But all in all, biologics have definitely changed the way I manage my medication. It's the main why I can live the way I do, pain, and live almost normally. So I'm very, very thankful for this, and I'm very thankful to be here today. So if anyone has any questions, I'd be happy to answer any in the Q&A session at the end, or if anyone would like to chat one-on-one or just have someone else in their network of other people who know what it's like to have JIA, I would be happy to do that. My LinkedIn is on the screen, or if you'd like to reach out by email, you can just contact Capri to chat. Thank you so much.
Thank you so much, Julie. It was amazing to hear your experiences, and I just thank you so much for sharing them with us. It really brought to life for me at Cassie and Friends. So we have youth leaders, we have parent leaders, and we walk these challenges of biologics with people every day, but we also get to celebrate like these amazing life-changing successes of biologics that I think you shared as well. And also provided just some insight into like all the things that you have to think about and that you manage. And that's like no doubt what makes you such an articulate, amazing 20-year-old. And we just really thank you again for being here today.
Thank you so much.
So with that, hearing from Julie, we're going to transition now to our medical speaker today, which is Dr. Lori Tucker. Dr. Tucker, as you can see on the screen, is a pediatric rheumatologist at BC Children's Hospital. She is the head of their division, and she's also a very cherished and important critical piece of the Cassie and Friends family, as not only a member of our board, but one of our founding members, who I think really helped Cassie and Friends develop the unique way that we're able to work with your clinic teams to get down to the heart of what is going to transform the lives of kids and family. Dr. Tucker is also an accomplished researcher with a specialization in autoinflammatory diseases and one of the founding members of the Canadian Alliance of Pediatric Rheumatology Investigators. Lori is a true champion for kids, as we often call it at Cassie and Friends, and I'm really excited to have her here today to present on biologics.
Thank you so much, Jennifer. And thank you, Julie. I think that presentation was just amazing. Really, really fantastic to hear from you about biologics. Now, why is this not going to see if we can, right. Let's try this. Yes, okay. I'm really delighted to be here today with you all to talk about a topic that I know is really important to many of you, biologic treatments in pediatric rheumatology. And many of you who are watching today or later have faced, are facing, or will face the decision to start a biologic to treat your child with a rheumatic disease or yourself. And I hope in this talk we can provide you with some practical understanding of this very important and powerful tool that we have in pediatric rheumatology. There are so many questions to answer. In this session, I'm going to describe what a biologic treatment is, how they differ from other medications. We'll talk about why and when we recommend them, their effectiveness, side effects to think about, and briefly touch on the steps for getting onto biologic medications and briefly talk about getting off biologic medications. So what is a biologic medication? A biologic is a protein-based drug derived from living cells that are cultured in a laboratory, and it can be made up of sugars, proteins, nucleic acids, or complex combinations of these substances, or sometimes are living entities such as cells or tissues. So it's quite a broad group of treatments. Many of these treatments are produced by new biotechnology methods. Now, there are biologic treatments you know. Vaccines are biologic treatments, such as the vaccine we're all talking about for COVID. Blood and blood products are biologic treatments, skin grafts, and Botox for those of us who need that kind of treatment as well. On this slide, I've listed some of the common biologic medications that we use in pediatric rheumatology. These medications are sometimes given by injections, sometimes IV infusions. Some of the medications come in two formats, either IV or injection, and in green down at the bottom, tofacitinib is one of the newer biologic medications, which is actually oral. How are biologics different from the other medications that your children are taking? The reason they're different is that these medications specifically target parts of the immune system that are known to drive the inflammation of rheumatic diseases. And because of this, they are immune suppressing. They moderate pathways in the immune system. I wouldn't be a proper card-carrying rheumatologist and immunologist if I didn't show you one of these crazy schemes, but this is actually a slide that is a complicated set of pathways that show how biologic treatments block pathways that lead to inflammatory diseases. On this slide, you can see a variety of types of cells that are involved in inflammation. And if you look at the areas where the red arrows are, some of the medications that you know are listed, and they show how they block certain of the cytokines involved in inflammation, such as TNF or IL-1 or IL-6. One of the very common questions that we get asked by parents are biologics safe? What are possible side effects? Some of the possible or potential side effects are listed here. I think it's important to note that many children take biologic medications and absolutely have none of these side effects. And so that's really important to know. Just because your child's on a biologic does not mean they are definitely going to get a side effect. Because these medications are nearly all given by either injection or infusion, some children will get an infusion reaction or an injection site reaction. Some of those injection site reactions are transient, so they get better over time. We do blood tests to check for low blood counts that can occur in some situations, or liver test abnormalities, which can reverse if we stop the medication, or increase in cholesterol or other fats in the blood. Occasionally, some children complain of headaches that seem related to biologics. Because of immune suppression, we have to look out for infection, either minor infections like skin infections or urine infection, or sometimes more serious infections. It's important for children on biologics to avoid live virus vaccines because of the risk of reactions. Two very rare potential side effects of biologics are, one, demyelinating disease, which is a rare kind of biologic condition. This is very, very rare, but your pediatric rheumatologist might ask you if there is multiple sclerosis in your family in close relatives, and this might drive the choice of medication because multiple sclerosis is also a demyelinating disease. The question of the possibility of increased cancer risk later in life is truly not been clearly proven for JIA or other rheumatic conditions. There have been rare cases reported in kids with JIA, but very rare, and also in kids with inflammatory bowel disease. One of the questions that comes up frequently in our clinic now is, can my child on a biologic get the COVID vaccine? Yes, they can. And yes, we recommend it. You should check with your pediatric rheumatology team for the timing of the vaccine or any need to modify your child's medication when they get the COVID vaccine. The other question that people ask, and I think it was in the chat, is do biologic treatments cause long-term problems? I think the important thing to note is that most of the biologic drugs only last in the body for a very short period of time, either days or just weeks, and that's why we have to give them frequently. The effect on the immune cells, changing those immune pathways, is also short-term. These medications don't build up in the body or cause problems in organ functioning in the long term. I think there was one question as to whether biologics can cause infertility later in life. As far as I'm aware, there is not any evidence to show that children who've been on biologics have problems with fertility later in life. One exception could be rituximab. This medication is used more commonly in kids with lupus, dermatomyositis, vasculitis, and this medication suppresses a certain type of immune cell called the B cell that makes immunoglobulins that fights infection. And in rare cases, there are some patients where their B cells are suppressed for several years, even after they finish taking rituximab. So this is something that we watch out for, and we do alert families to this before they start the medication. We'll talk for a few minutes about the clinical situations where biologics are used in the rheumatology clinic. This is a changing and expanding field because we learn more about these treatments and their efficacy. We won't have time to talk in depth about all of these conditions, but we'll touch base on some of the common situations that arise. What are our goals for treatment of children with arthritis and rheumatic diseases in 2021? Number one is tight disease control, and number two is early disease remission. That means no evidence of active disease. We know that this provides the best chance of long-term excellent outcomes with limited damage. So when do we recommend a biologic to your child? Well, in children that have severe disease that is organ or life-threatening. So for example, children that have eye inflammation that can cause permanent vision loss, children with dermatomyositis who are quite severely weak, children with systemic JIA that have widespread inflammation in their joints, but also in other organs in their body. We would recommend a biologic, and sometimes quite early in disease. We also recommend biologics when we were unable to control disease with standard treatment, and I suspect that's the case for many of your children. For example, children with JIA who have continued active disease on naproxen and methotrexate, uveitis that flares and we're unable to stop the steroid eye drops, vasculitis or lupus where there's severe disease or flaring disease. Systemic JIA is a separate and interesting disease, and we'll talk about that in a few minutes. I show here the American College of Rheumatology guidelines from 2019 for the treatment of JIA. These were developed by a very diverse expert panel of pediatric rheumatologists from the US and Canada after very extensive literature review, and many of us use these guidelines every day in the clinic. I wanted to point out, if you look at the red arrows, that adding a biologic is now considered standard treatment in children with JIA after early failure with methotrexate if disease activity is still moderate to high. And here on this slide, to demonstrate how many children have been treated with biologics around the world, in this slide, I look at 3 studies from registries that are in the Netherlands, Germany, and Sweden for children with JIA. And if you take all 3 of those registries together, over 15,000 children have been reported who were treated with biologics for JIA. The majority of these children were on methotrexate together with a biologic. And because most of these studies reported their outcomes about 10 years ago, etanercept was the most common biologic used, followed by Humira. This slide shows some recent data from our own pan-Canadian Capri JIA registry. Up to 2020 December, we have 465 children newly diagnosed JIA that were enrolled in this registry. And that means these children were enrolled in the registry from the very onset of their JIA. And if you look at that graph, what we find is that among those 465 children, there is a 23% chance of starting a biologic within the first year of disease. So this is just to give you an idea of how commonly are we recommending biologics to children with JIA. Are biologic drugs effective for treating JIA? If you look at a variety of published studies to date, you will see that biologics are remarkably effective for children with JIA, particularly when you take into consideration that these are children, for the most part, who failed methotrexate treatment. If you look at a summary of recent literature, about 60% of children put onto biologics significantly improved within 6 months of being on a biologic treatment. And 1/3 of these children improved by 90% by 6 months of being on a biologic drug. Again, if we look at the German Pediatric Rheumatology Registry for JIA, and this is a biologics registry called BIKER, they reported in 2015 their real-world clinic experience. And why is this important? It's because it's not a drug trial. There were 2,000 children on etanercept. 75 to 80% of them improved by 50%, and 28% of them were in complete remission of their disease by 1 year. And this was with minimal side effects, either minor or serious. So these are very effective drugs. I wanted to mention systemic JIA because this is a slightly different type of arthritis in which children present with fever, rash, and organ inflammation. And our usual treatments in the past were naproxen, steroids, prednisone, methotrexate for arthritis, and sometimes cyclosporin for children that had widespread inflammation. And what we know now from studies that have been done in the US and Europe and Canada is that using biologic treatment very early in children with moderate to severe JIA can rapidly control disease, allow children to come off prednisone, and in some cases even avoid using prednisone altogether. And to my mind, this is a real sea change in treating this disease, which can be very severe in some children. In children with eye disease, uveitis, who have severe inflammation, we work with the ophthalmologist in children who have either severe inflammation or persisting disease, and they were unable to get control on methotrexate, and often using either one of the 3 biologic medications that are listed on the slide here. Children are able to stop their steroid eye drops, not develop flares, and not lose any vision. So it's really important new drug for this disease. Lastly, what if the first biologic drug doesn't work? Or what if your child flares after being on the first biologic drug for a while? In a study that was published in 2020 of a UK registry of children with JIA started on biologics over quite a long time period, it had over 2,000 children and teenagers who started on a biologic. And what they reported is over that time period, 23% of them needed to switch to a second biologic, and 5% of them switched to a third biologic. we really have an expanding group of biologic medications in our armamentarium for children. And I think if we find if the first biologic drug doesn't work, we switch to a new one. What's a biosimilar? Well, this is a question that a lot of families are talking about and asking about. You probably have heard about biosimilar treatments. These are somewhat like generic drugs. They're very similar to a name brand biologic, but they're not exactly the same. And the reason is generic drugs can be exactly the same because they're chemically identical. Biosimilars may have some slight differences from the original drug because they're made in a different way, but they're similar. Health Canada will approve biosimilar drugs for the treatment of disease if they find that there's no clinically meaningful differences between the biosimilar and the biooriginator in safety, in quality of the drug, or in efficacy, how well it works. And why does Health Canada and the provincial health authorities, why do they want to use biosimilars? The reason is that biosimilar medications are far less expensive compared to original biologics. On this slide, what I'm showing is that the cost of biologic drugs in Canada rose to, in 2018, $7.7 billion. Now, this isn't only for kids with JIA. This is adults with rheumatoid arthritis and other inflammatory conditions where people were using biologic drugs. But it was really, there's been an astronomical increase in cost to government for these medications. This is the reason why Health Canada and other jurisdictions want to be using biosimilars. Over the same time period, if you look at this graph on the bottom line, there's been some uptake of biosimilar sales, but not really very high. I put on this slide the names of some of the biosimilars that you may encounter in your when in your clinic visits for etanercept, for adalimumab, for infliximab. There are others. The anti-IL-6 or IL-1 agents, tocilizumab, anakinra, and canakinumab, there are no biosimilars that are available in Canada yet, or for abatacept or rituximab, or for JAK inhibitors. Sometimes families have concerns about switching or starting a biosimilar. Will it be as effective? Well, adult studies in arthritis have shown equal effectiveness of biosimilars that have been studied to biooriginal drugs. We also know that biosimilars have been used for children in other countries where they never had biooriginators, and it's been used safely and effectively. Is it as safe as the biooriginator drug? I will say that testing in adult patients, both here and abroad, is very reassuring. General use in other countries, and that is even including children, is very reassuring. And early use in our Canadian cohorts is also reassuring that these are equal in safety to their biooriginator drugs. Sometimes people will, there are some interesting data that shows in open testing of biosimilar switching, in some cases, they seem to be less effective. And you might wonder, why is that? There is something called a nocebo effect, and that is rather like the placebo effect. If an individual is told, I'm switching you from a drug that you're on, that you're doing well on, to something, and the individual is concerned or they feel that this might be less effective, that there may be negative expectations from the person themselves, and they may perceive that this is not working as well. So I think we have to be very cautious when we interpret the evidence about how effective these medications are in switching. So what if you have considered the options with your pediatric rheumatology team and you and your child are ready to start a biosimilar or a biologic medication? What are the steps? So generally, your child will have to have pre-screening lab tests and an immunization review. You will generally get enrolled into a patient support program for the biologic that you have chosen with the physician. There will need to be applications for provincial health coverage or extended health insurance as appropriate, and you will work with your pediatric rheumatology team regarding how the drug will be given. There are biologics coverage options, and there are a variety of them because these are very expensive drugs, even the biosimilars. These differ between provinces and across individual patient and family situations. Patients may have a combination of government coverage, private coverage, deductible payments, followed by full coverage by government or insurance. In very rare conditions, particularly in rare diseases, where there isn't an indication for a particular biologic for that disease, a pharmaceutical company may even provide compassionate use drug for a period of time. The process of getting coverage for a biologic medication is more complicated than just picking up a prescription, and it requires your active participation in this process. You will need to consent to having a patient support program be involved. They will contact you for information about any insurance coverage you have, and they'll work through getting the coverage. Your physician may need to support an application on your child's behalf to provincial funding agencies. You may need to be in contact with your extended insurance company, and the medical team may need to fill out forms for your extended insurance company. Once your child is on a biologic, there are some important things to remember. Your child needs to have regular clinic follow-up, and you must do the requested lab tests at 3 to 4 monthly intervals, or whatever your team recommends. Why is that? It's because when your medical team is asked to renew your prescriptions, they're going to need information about how your child is doing and the lab tests. You and your child need to be alert for infection and take your child into the family doctor or emergency room when sick and necessary. And lastly, please answer calls or communication from the medical team or the patient support program. There have been families who've written in questions asking, when can you stop a biologic? My child's been on a biologic, we'd like to stop. And this is a topic of some controversy. And standard guidelines are not yet available, particularly in pediatric rheumatic diseases. In general, particularly in our program, we wouldn't consider stopping a biologic until a child has an active disease. It's difficult to say for how long, but it might be in the order of months to a year or so. This decision is discussed with the patient and family, and factors that might play a role in how we decide might be how many flares the patient had in the past, how difficult their disease was to control, and what level of disease damage is present and the risk for more. The risk of disease flare after stopping a biologic may be as high as 70% in some patient groups, so this is something to consider. We and Dr. Berard and Dr. Luca and all of the pediatric rheumatologists in Canada are now involved in a very large active international research project between Canada and the Netherlands called You Can Do. And this is one of the critical questions that we are studying in this research program is how can we find biomarkers to tell us when it's safe to stop medications? Okay. I think I've talked enough. I'd like to thank you for the opportunity to speak with you all today about this topic. And I'm going to hand it over to Jennifer Wilson. And I'm really happy to, together with my colleagues, answer questions. I think I'm going to stop sharing my screen.
Thank you, Lori. I feel like you could keep sharing forever. So many questions. And this is something that in Cassie and friends all the time. I mean, it's daily. There are a ton of questions around biologics, and I think the overview of information you presented is going to be a resource for many, many, many months to come. Obviously, biologics is a new area, fairly new, and will continue to evolve. So for today, I'd like to invite Julie to turn back on your video. And then I'm also really, really excited because the whole issue of biologics, and Dr. Tucker also mentioned biosimilars, can vary widely from province to province in terms of many, many factors. I'm excited to actually have our full medical advisory committee here to participate in the Q&A tonight. So that's Dr. Bobby Berard, who is with London Health Sciences Centre, and Dr. Nadia Luca, a pediatric rheumatologist at Alberta Children's Hospital. Welcome, everyone. And it's always interesting when there's so many questions, knowing where to start. But sometimes I think it's best just to start at the very end. So obviously, we have a lot of parents whose child is on a biologic. for whatever extended period of time and wants to know about that exit period. How long can a child stay on a biologic safely? But also, and I think this is one of the most important questions that parents have, why does a biologic work well for years? My child's stable. And then one of the most heartbreaking things we go through with families is when that medication stops working and you switch to another. And I think I'll start back with you, Dr. Tucker, and then if Bobby or Nadia want to jump in, we can do so after.
Yes, I think, I think this is part of the reason why I hope as many of you who are eligible are part of our Capri JIA registry, because really we need to study this and we need to follow this and figure out how we can predict which child is going to do well on which biologic. And that, again, is part of this You Can Do research project. So I think we're kind of working on it. It is definitely true that we have patients, I'm sure Dr. Berard and Dr. Luca also have patients who do brilliantly on one biologic for a period of time, and then it loses effectiveness. There probably is an immunologic reason for this, whether or not it has to do with the patient developing some antibodies to that one biologic that inactivates it, or whether their immune system shifts to a different the good news is that we generally always have alternatives. And so if one is not working properly, we will talk with you about, what the other options are. I know that's really difficult for kids and families. You get used to one thing and you think, oh, we're back to square one. But I feel like I guess I'm a glass half full person. There's other options and, we can find something else, hopefully that will work for you. I noticed in the chat, there was also, or the Q&As, there was someone who asked, why is my child still on methotrexate and a biologic? And I can answer that really quickly because it has to do with this question. It's because the biologic medication, taking the methotrexate, helps prevent your child from making an immune response and inactivating your biologic drug. So that's why. It's kind of standard, but I'll let my colleagues chime in.
Maybe I'll just throw an additional question in for your chiming. Is there a hierarchy of biologics? So someone's asking, like, when a child fails a biologic, is there like a list that you go through? So how is the next one chosen? And maybe we'll go to Dr. Berard.
All right, thank you. Thank you for that question. So I think thinking about listening to Dr. Tucker respond to that, I was this hierarchy question. I think if you have a patient that's on a biologic and does well for a period of time and then loses effect to it, we look at that more as what we say a secondary failure to the biologic. So it worked really well, and then perhaps your body developed a tolerance to it, so made its own blockers to the medicine. So the medicine lost its effect, which is again ties into why we keep the methotrexate around, to try to stop your own body from blocking the effect of the biologic. So if you have a patient that's done really well, for example, on Enbrel or Remicade or Humira, which are all sort of in the same family of how they block the immune system, but then they lose their effect, we would then most often choose another medicine from that same class, thinking the patient did well on that to begin with and they lost the effect. So we're going to choose something that's similar but a little bit different to try to trick the immune system. So I think in terms of that hierarchy question, I think it depends on whether the patient failed right from the beginning, and in which case we would choose a different mechanism altogether to block the immune system. So for example, if you were on something that was blocking TNF and it never worked at all, we might choose blocking by the IL-6 method or by how T cells talk to each other method. We might pick a whole different way of blocking the immune system. Whereas it's different if you had a good effect, but then it waned over time, we would probably more likely stick within that same class. That makes sense.
Mm-hmm. That does. And maybe we'll let Dr. Luca finish with the trifecta here of our medical advisory committee. Are there a maximum number of biologics that a child can try?
Yes, hi, thanks for that question. To my knowledge, the short answer would be no, there isn't a maximum. We are limited by a few things. One would be what is available to pediatric patients, and also what insurance and or government plans are willing to pay for, or whether we could get compassionate coverage of additional biologics over time. But in terms of trying different drugs within the same class and or different classes, we definitely would be willing to keep trying until we find the one that works for you.
Right. Great, thank you. Thank you. We have some questions around the side effect of being immune compromised due to biologics. And I think Dr. Tucker addressed this in her presentation, but maybe if you just want to recap, and then I thought maybe even Julie might weigh in on any considerations as a patient on a biologic that you take around the potentiality of being immune compromised. And I think in our the people online today, like in a school setting, like cough and cold flu season, and after an infusion, like, is there any consideration about going back to school? So maybe Dr. Tucker, if you want to get started, and then Julie, I'd love to hear your thoughts on it as well.
Yes, I did see that one of the questions in the chat was, should my child go to school after their biologic infusion? The short answer is yes. We have quite a number of, we have a lot of kids that we care for in BC who are on various biologics. We don't recommend that anyone stay home from school or activities because you're on a biologic. We would recommend that people take reasonable sort of precautions to keep your child from contact with in a setting where there's people actively infected, teaching kids to because of COVID, most kids are getting quite good at hand hygiene, and that sort of thing. So we generally don't recommend any restrictions to activities because of being on a biologic. Is the short answer. Really, the more tricky situation, I think, has to, the considerations around being sure that what the vaccine, other than the COVID vaccine, there are some live virus vaccines that come up, knowing which vaccines that your child can get or should, have postponed. If your child has to have some other kinds of procedures, dental procedures and things like that, just reaching out to your team and making sure that no special precautions need to be taken. But other than that, we don't recommend any restrictions.
And so from recommendation to practice, Julie, just tell us about your experience, or like what your thoughts are around that, or if it impacts your life and the way you go about life in any way.
Yeah, so because I've been on biologics for so long, since I don't remember the exact age because I was young, but I want to say about 10 years old, it's kind of been instilled in my brain that I need to be careful about germs, and I have to pay extra attention to not get sick, just because I can get sick easier and it's harder to recover from that. I noticed that once when I was younger, I got the chicken pox, and they actually put me in isolation in the hospital because of it. Not because I felt like I was dying or I felt bad, just for my own protection. And also growing up, I played a lot of sports. So I noticed that whenever I would have sports injuries, I found they would take longer to recover. So that again would go into consideration when thinking about being on biologics. I just have to be a little bit more careful in general. And I've definitely put that into practice, especially since COVID-19 started. Just by having that instilled in me, it did make me a little bit stressed during COVID, just because I wasn't 100% sure how I would react if I got COVID. So I was definitely more on the careful side throughout this entire process. But overall, it hasn't really affected the way I live my life. I don't really change anything. I just kind of make sure to sanitize all the time, and I don't like touching the germs on the bus, and I just try to be a little bit more careful overall.
Amazing. Thank you, Julie. Okay, I think we're going to switch because we have a whole swath of questions about the administration of biologics. And so one of the questions that we have is around especially in a child who has needle phobia or non-compliance issues. We have one parent, and we've heard this before, that is given the biologic while the child is sleeping. And maybe we'll just go straight to Dr. Luca, because then we're going to talk about citrate for Humira as well. But let's start first with just generally, how do I give my child a biologic? And when there's issues, what are some of the things we can do?
Yeah, this is a really common issue that comes up and affects kids and adolescents of all ages. So it's something we anticipate. Certainly, there's many different strategies, and it depends also on the mode of administration, whether it's an injection versus an infusion. Sometimes that plays into it as well. In terms of just general strokes on that, we always talk about easy stuff that can be done. So one is, making sure that the medication is at room temperature and not coming from the fridge, because that tends to be more painful. In addition, if there's a way to either numb the skin with ice, or as Julie had mentioned in her talk around the topical anesthetics, can also be very helpful to prepare the skin. And then some people find that using a syringe as opposed to the auto-injector pen is beneficial, because they can control the speed of the injection and kind of feel like they know what to expect. And I think, Julie, you mentioned that as well when you were talking. Whereas other people say, oh, I don't want to see the needle and I'd rather use a pen, right? So it is very individualized. As far as, younger kids and possibly those with complex needs, we very often will involve child life in this sort of discussion and preparation for the family, because it can get very stressful and anxiety provoking. And so there are lots of different strategies that child life can go through with the family. And I'm sure there's lots to talk about on that, but I'll just sort of skip to also say that if injections are not possible because of how much anxiety it causes, we also do have medications that are given as infusions, which may be an option for your child if they really cannot tolerate. So we always think about, would it just be better to use an IV infusion in this scenario, if we have that option, of course. So I don't know if that answers kind of the more general piece.
Absolutely. And I think, Julie, you gave some great tips around numbing cream. Do you have any advice, Julie, for parents with a child who is either anxious or resistant, or anything that helped you in your journey, which you told us about, obviously your story around the pivotal fight that launched you into self-injection territory, but before that?
Before that, honestly, I was a little bit nervous. I did start injections before biologics when I was on methotrexate. So it was just nice not having to do it myself, having someone else to do it. I know someone had mentioned doing it while they're sleeping. I wouldn't recommend that. If I woke up in the middle of the night and saw that, I would be a little bit more freaked out than during the day. But maybe just if there's a set time, I think it would allow you to kind of mentally prepare for that session. And maybe if you could make kind of a fun routine out of it. So after the injection, oh, it's like weekly ice cream time or something like that. So they have something to look forward to, even though they might be a little bit scared of the injection.
Thank you, Julie. And I think just, from the Cassie and Friends side of things, like, because we've talked with lots of families, is that definitely, like, if you're struggling, talk to your pediatric rheumatology team, and they're there to support you through it. And it is challenging, or it can be challenging. So just make sure that you communicate about the challenges, and also that we do have an online support network with lots of parents who have, like, minute by minute plans after years of experience on how to do their injections, especially Humira, which we're going to talk about next. So definitely rely on this community and reach out for support if you need it. So we're going to switch over to, we've had lots of questions about citrate-free Humira as well. And if anyone has a child on Humira and isn't familiar with the term citrate-free, the citrate is the preservative in Humira that causes, or is linked to, the stinging sensation, so that the painful, that burning feeling with the injection. I think probably the best way to start with this one is actually just to do a little round robin, because one of the reasons we have Dr. Tucker, Berard, and Luca here is that we're representing BC, Alberta, and Ontario. So maybe we'll just go west to east. And if you could just say, like, is citrate-free Humira available to your patients? Are you prescribing it? And any kind of details you can fill in around that. So Lori, you first.
Okay, well, in BC, we only have Humira option for patients until October 6th of this year. And anyone newly starting on adalimumab, that's the drug that is Humira, has to start on a biosimilar. We don't have citrate-free Humira. And the good news is that several of the biosimilar adalimumab drugs are citrate-free. So quite a number of our teenagers were actually begging to go on a biosimilar and have really appreciated that option. So yeah, that's where it stands here.
Awesome, thank you. Dr. Luca.
Yeah, so similarly, here we do have access to the 20 milligram dose for the citrate-free Humira, but we don't have access to the 40 milligram dose citrate-free Humira. But then in terms of whether you'll get coverage for that originator drug versus a biosimilar would depend on insurance. And they are, in terms of government plans, they are asking that everyone start a biosimilar as well, similar to BC. And as Dr. Tucker said, it's actually been going well because a number of the biosimilars are citrate-free and really well tolerated.
Thank you. And Dr. Berard?
All right, so here in Ontario, we also have access to the 20 milligram citrate-free Humira, but that would only be for children under 30 kilos. So we have access to that. As far as I understand, in Canada, we will never have citrate-free 40 milligram Humira. So that's for any child over 30 kilograms. That's not coming. So in Ontario, as of March of this year, for adalimumab, we have 5 biosimilars, 2 of which, so the Amjevita and Julio, are both citrate-free and come in the 40 milligrams. So as of now in Ontario, for first start biologics for kids for either their juvenile idiopathic arthritis or their uveitis, the government plan is mandating biosimilar first start. So with adalimumab biosimilar. But I have to say that in the last 6 months, so as of right now, private payers haven't mandated first start with biosimilars, but I'm sure that will come. But I have to say in the last 6 months, I have presented to my patients all of the options in terms of, because when I'm starting a class of TNF agent, I talk about Enbrel or etanercept, I talked about Humira or adalimumab, and I talk about the adalimumab biosimilars, and I present all the options. And all of the new starts that I've had in the last 6 months, the patients themselves have chosen a biosimilar because of the possibility or option or hope that there's going to be less pain with injection. There are patients that have never experienced it, but I'm relaying information that I've learned from other patients. The other piece would be, and I know Dr. Luca mentioned this, here in Ontario, we can't actually access IV Remicade, for example, on the first go round. We have to have failed one of those other ones. So if you're having a child with a lot of difficulties with local injections, that's an option. We'd have to make a really compelling case because they don't tend to, they don't fund IV infusions off the first hop for us anyway. So that's sort of the landscape in Ontario now. Mm-hmm.
Amazing. And I just want to say, if anyone is on this webinar and maybe you haven't started a biologic or approached that, but we're interested in the topic and are feeling really lost, it's because it's complex. And so I think, really, if you have questions, again, ask your team, but also, if you are having challenges or you're having successes, like I think the best way as a community that we can keep on top of this and understand it and navigate it together is to share your experiences. And so I would just encourage anyone, Cassie and Friends is here not only to provide support, but advocate for this community. And so if you do have experiences that you feel compared to share, please do reach out to us and let us know. Like it's difficult to keep our finger across all provinces, but it's so important. And the more that we can speak together and share our stories, I think the much better chance we have of getting the right mix of medications, access, and just, what Cassie and Friends always says, those pain-free futures that we're really focused on.
In particular, I'm particularly interested in hearing from families who have questions or are interested in sort of advocacy. And by advocacy, I don't mean, the kind of, my child's on Humira and I'm never changing and that's the end of it. I think advocacy that is collaborative and cooperative and working together with government. And so, for example, in BC, I've been having collaborative teleconferences with PharmaCare, the funders, the government funders, and some people from higher up in Amgen to talk about what challenges families are facing and, frankly, to strong arm them into providing the kinds of resources or things that our patients need here. So you all on the call are an important part of that, because if we don't hear at Cassie and Friends what you're all struggling with, we can't really help. So I echo that. And can I say that I think all of you on the call who administer injections to your children are total rock stars. I just want to tell you that, whether you do it during the day or when they're at sleep or whatever you do, I just acknowledge that this is a hard thing to do, and you guys are fantastic, really.
Absolutely. I think that's a good place to switch gears back to Julie as a rock star who takes medications. Julie, we have a great question actually from another youth in our community. And the question is about managing medication. So in conjunction with your biologics. And have you ever felt any issues or stress when adding extra medications to your routine? How do you manage?
I just have to do a little bit of research before I start any medication. I always talk to my doctor as well as the pharmacist just to get a couple of different points of view, just to make sure nothing within the medications will mix. And then I also just really listen to how my body feels. It's hard to tell whether it's because I'm taking the medications at the same time or if it's that individual medication that I'm not reacting well with. But it's very much a situation where you just need to listen to your body. So a piece of advice I'd like to reiterate for anyone, or especially for parents, would be to communicate with your child that has the condition, because they won't lie about how they're feeling. So you really have to listen to what they said. And I know last time I mentioned I wouldn't like having injections in my sleep, but that's if someone were to surprise me. Again, speak with the child, make sure it's what they want. And I think communication is the biggest thing there.
Amazing. Thank you. Okay, so we have a few specific questions. So I'm going to do the medical lightning round. So Dr. Luca, okay, there's not a lot to this question, so I'm hoping that but it says, should we check for antibody levels?
I think that probably came up when we were talking about losing effectiveness to some of the biologics and how the body can make antibody levels or antibodies to the medications. And so as far as I know, we are only able to check antibody levels for adalimumab and maybe infliximab, but I believe so. Those are the two that we have access to order those antibody levels. And as far as making that decision as to whether we should order them, it would depend on the clinical scenario. So that scenario where a patient had a great response and then it sort of dropped off and they started to flare, that would be a situation where we would consider ordering those levels.
Thank you. Dr. Berard, could a low neutrophil count be due to biologics? And if so, how low is it okay for that count to be?
That's a great question. So the low neutrophil count associated with the biologic most commonly associated with low neutrophil count is tocilizumab, which historically was by IV infusion, and then the pandemic accelerated our access to home subcutaneous injections here in Canada, which was a wonderful success of the pandemic, I guess. And so generally my threshold for sort of concern would be under 1.5 for the neutrophils. So I would tolerate sort of between 1 and 1.5 for a little bit. And if it was a trend, I might try to space out the dose by a couple more days. Certainly really your risk for significant infection would be present under 0.5. So I kind of like to keep it above 1 for sure, but it really depends. And if it's not severe, I'll follow it for a few months to see where this is at. And I also will do blood work like on the day that your tocilizumab is due to see the highest that it is right before you're going to get your next shot. So I kind of play around with that, but we like it probably 1.5 and up is what I would say.
Yeah. Thank you. And Dr. Tucker, so there's a question about whether, and I think you talked a little bit about this in your presentation, but the question is really about a relationship. Is there any relationship or studies that show a relationship between the length of time a child is on a biologic treatment and their chance of remission or outgrowing JIA?
I don't think there really is any good data to make any, to make any statement about that, because I think it's highly variable from patient to patient. What I can say is we do know certainly, and again, it's specifically for the kids who have systemic JIA, we have some really good evidence that early treatment with a biologic turns off this whole inflammatory cascade that's happening in that disease. And many of those children actually are able to discontinue their medication effectively and go into a long-standing remission. For the other subtypes of juvenile arthritis, I think we're starting to understand a little more about, using biologics early, turning off the inflammation, but actually saying if you stay on the drug for 1 year, you're more likely to flare versus if you stay on for 2 years, you're less likely to flare. As far as I'm aware, I don't think we have the information to make those kinds of statements. And often it really has to do with an individual patient, because a patient who's had multiple disease flares previously, every time we've tried to discontinue medications, is really different than someone who came under really rapid control and never flared after that. And so I find in our practice, we tend to look very carefully at the individual kind of disease course and discuss with family and kids and make a decision based on that.
Thank you. And I think I'll stick with you for one more second. And I think this is such a brave question to ask, and it kind of makes me a little emotional because we know how hard and where this question comes from. And this is from a parent with a child with enthesitis related arthritis. And the question, there was a couple questions connected to ERA, but I think this one got it. It's, is there a best biologic for ERA, and will it actually take the pain away?
So the answer is there are several of the biologics which likely are going to be more effective for a child that has ERA. And really, talking that over with your pediatric rheumatologist, it is very likely that they will recommend one or two of, options that would be more likely to work better for a child with ERA. So the answer is yes, some biologics are better for ERA than others. And I know that we know that children with ERA have more pain than children with other subtypes of JIA. And in fact, they're often a little bit more difficult to treat and get under control. I think that all of us are starting to move to treating kids with ERA more earlier in disease with biologic treatment for that reason. So I would hold out positive hope that getting on biologics earlier in the course of disease is more likely to afford better pain control, because the pain is coming from uncontrolled inflammation. And other medications that we use, like methotrexate for treating, polyarticular JIA, may not be effective for the enthesitis that we see in ERA. And that's why kids with ERA have more pain. So I hope that, your child, or I hope that, that helps you with decision making and gives you some positive thoughts.
Thank you, Lori. Dr. Berard, we have a question, and I think this probably comes up sometimes in clinic. And so how would you guide or talk with families who are asking about a naturopathic or other approach than biologics?
Okay, thank you for that question. So certainly I'm not sure if the way the question was written, if it's a naturopathic approach to treating arthritis or it's naturopathic approach in the context of choosing that versus a biologic. I think for me, I'm very open to incorporating alternate strategies to help manage arthritis, as long as it's not going to interfere with the medications we're using or interfere with helping the child to get to a pain-free life without arthritis. So to my knowledge, there's no naturopathic therapies that have definitively shown the results and benefits that we see with use of medications like methotrexate and biologics. So I really encourage my patients to communicate with me if they'd like to try alternate therapies, to disclose that. But certainly, I think a really big game changer in rheumatology that's changed the face of arthritis has been the biologics. And I think, just witnessing, 360-degree turnaround in our patients just brings us so much satisfaction as care providers, and seeing, how it's changed children's lives. I think, I would be remiss of me to sort of go a naturopathic approach rather than the therapies that I know work well and have a favorable side effect profile for the benefits that they're going to bring to that child and their family. So I'm not sure if that's the question that was intended, but certainly I'm open and encourage open communication about alternate therapies as well.
Thank you. I think we'll go back to Dr. Tucker one more time, and then I think Julie will go back to you for the final word. But Lori, what is the hope, or the 10,000-foot view? What's next in biologics?
I would say there's a couple of things. One is, I think I touched on this oral biologic tofacitinib, and this biologic medication is in a new class called JAK inhibitors. So this is a class of drugs that inhibits a different, part of that pathway in that, very complicated diagram I showed people. I think what's really exciting to most of us is that these JAK inhibitors, they're being used widely in adults with rheumatoid arthritis, in other inflammatory conditions. They're quite effective. They're oral medications. Maybe we can get away without injections. And I think that that is a path that I think we're going to start looking at more and more for kids with rheumatic diseases. So I think, and that will be over the next couple of years, hopefully, we'll be able to start using, we can use tofacitinib now. It has an indication for polyarticular JIA, but maybe some of these other drugs will be able to incorporate into our use of, and get away from having to inject kids in their sleep. That would be fantastic. So I think that's one thing. And I am sure that some of the research that's going on through UCAN, through other areas, is going to bring us to a point where we will be able to do some sort of test on a child with JIA to tell us which of these drugs is the right drug for them. So that would be whether it's a blood test or a urine test or a saliva test. But I think we'll probably, those are the two things that I think will really be, will provide better personalized choices for children. So we won't be saying, try this, try that, we'll try this. We'll have better choices. So those are things to look forward to.
Unmuted. A lot to look forward to, and we're excited to keep working with all of you on this line, representing so many more in this community to make that happen. And so for our final question and to end the webinar tonight, Julie, you offered some great advice throughout your presentation. And I just wondered if you would speak directly for a second to either a youth or a parent who are just about to start a biologic or talking about one, who might be feeling nervous about that or not sure what to expect. And if you just had any thoughts about what might help or from your experience, what they should anticipate.
I think the biggest thing is having a support system there. Just because growing up, I didn't know very many people with arthritis. I didn't know anyone other than my grandma until I reached my teenage years. So I think it would be finding those different support groups through Cassie and Friends. I found one also through Camp Cambria, which is a camp for youth with arthritis. Just finding people to talk to and to share perspectives and share ideas with. That's the biggest thing. And also you're not alone. You will make it through. Everything will be okay. If something doesn't work, there's always something else to try. But I would say the biggest advice to parents would be definitely talk to your children throughout the entire process, rather than making a decision for them and saying, this is what we're doing with your body. Just involving them in that decision making and making sure that they understand what's going on. That can be very beneficial for them in the long run. So I think it would just be communication and support would be the biggest things.
Thank you so much. And thank you to everyone here that joined us tonight. We are so thankful to have your participation. And if anyone has any follow-up questions, please do email them to info@cassieandfriends.ca, and we'll do our best not only to answer any questions that come in, but address some of the questions that came in tonight that we weren't able to get to. We always get short on time. I'm just going to go back to my screen for 1 second. And so thank you so much, everyone, for joining us. It'll take a second to get back in. So just in closing, a couple words from Cassie and Friends here. I just want to thank our sponsors one more time, Nicola Wealth Management, AbbVie, Amgen, and Sobi. This is really critical, this opportunity to connect with each other, to ask questions, to meet one another, and to feel like a community. And I think that the contributions that these organizations are making are just so important to Cassie and Friends being able to do the work that we want to do. We do have an online support network. I encourage you to reach out to other parents or to other youth, and Cassie and Friends is a great place to do that. There's the Cassie and Friends Support Network, and we also have a Facebook group, Juvenile Arthritis Canada, where you'll meet tons of other parents. I think there's 400 parents on the Facebook group now, and I think about 100 or 120 on the support network. So please do feel like those channels are always open to you to ask questions along the way, or even just hear other people and what they're experiencing can sometimes be a real comfort. Lastly, please do visit cassieandfriends.ca, check out our resource hub, check out the past recordings, and don't forget to fill out your survey after this session today to let us